you? We
Sure.
can invite
Let us kick off this, and for anybody here watching too, I also tweeted out the startups. So if you want to follow up with them, you can go on Twitter and maybe find them there. But thanks everyone, and thanks Ethan. And I don't know if you're going to stick around, Ethan. What time is it over there? 5 o'clock in the morning, 4 in the morning, or 3 in the morning?
No, we're not. I'm still even in the same day, so it's all good.
Okay, all right, but please stick around, guys, because you know, we had a really fun discussion in the first session, so maybe I'll get that fun again. And if anybody wants to chime in, the more the merrier. So this one is going to be not so controversial. This panel, it's on opening up and shutting down.
But why?
Not at all.
No.
And we have several people here, but I'm not quite sure. Archana, do you see them? I see Duncan here, but I'm not quite sure if I see
I see Emily.
the speakers. There's Emily, and then we're missing Leslie, and then Phil Kerpen as well.
Leslie has raised her hand from the attendees. Is she in the attendees?
Okay, so Leslie is, we can always change that. So
Yes.
Leslie, and also Phil. So I'm going to promote Phil to a panelist.
Mm-hmm.
Let's see if I can find Leslie. Sorry about that, guys. Maybe you just promote to panelist. There you go. So now we have we should have our panelist here.
Was I on the was I on the wrong link?
Oh, there you are.
No, you're in a different group.
But now you are there. Great. So Archana, I will.
Yes, you jumpstart.
You go ahead and try to. Well, again, I mean, I think everyone's heard this is the non-controversial topic of opening up and shutting down. Despite COVID fatality rates declining, we still have higher caseloads. What's the risk reward scenarios between reopening versus staying shut, especially for schools? Are the negative effects of job loss and financial stress and mental health deterioration in adults and kids far greater than the secondary effects? People talk about respiratory, cardiac, kidney problems. So we're going to talk about the risk reward of what we're doing from a pragmatic standpoint. So I'm pretty sure we're going to have another very conciliatory conversation around this topic. So with that, Archana, I'm going to pass to you so you can intro the panelists.
Yes, absolutely. So, welcome everyone. We had a very spirited conversation in the past panel, and I'm really hoping for the same level of bad blood here. So let's get started. And I have Duncan on my right side panel. Hi, Duncan. And I would like to welcome you, and would like if you could introduce yourself and share how you interact with COVID-19. That would be really helpful.
Duncan Davidson, Bullpen Capital, an early stage venture fund. Not an armchair epidemiologist, so I'll try to keep my focus on more broader issues or issues the tech community cares about. We have some digital health deals. One we actually adore is Carbon Health, which some of you may be aware of, but there are several others. We love telehealth. We love this whole direction. We think that COVID has accelerated underlying trends versus really changed anything. But that acceleration is something you can invest in. So how does it affect me? I'm part of the 40% of the country that can work remotely and still get groceries and still have stuff taken care of. So I'm personally relatively unaffected, and none of my kids have caught COVID. At the same time, I'm very cautious because my wife and I are in the at-risk category. So we wear masks and we do all the mitigation techniques. Having said that, I really feel for the people in the 40% that were heavily impacted by this, especially the two family parents where one of them had to stay home to watch the kids and he or she had to let the job go for a while. So in that sense, my perspective is quite the wrong one because the VCs kept trucking through all this while a lot of the rest of the country got really seriously hurt.
Thank you. And thank you for being, I think, sensitive to the fact that, there is a huge divide in the country, people who were impacted by COVID and people who were not. Either their lives were or their livelihood were. And so their perspective on COVID is very, very different than people who were not. So thank you. Emily, you are next on my screen, and thank you for joining. Please introduce yourself and share what your COVID experience has been.
Great, thanks. Well, thanks so much for having me today on this panel. My name is Emily Barson. I'm the Executive Director of United States of Care. For those who aren't familiar with us, United States of Care is a nonpartisan nonprofit organization. We launched in early 2018 around the mission that every person in the country should have access to quality, affordable healthcare. Over the past 7+ months, we've shifted our resources and efforts to develop resources and support COVID-19 response efforts by state and local or state and federal officials, and healthcare leaders and stakeholders, really keeping our focus driven by the needs and experiences of the public. It's part of our approach always, and in particular in this really challenging time, as was shared, we're all looking at this from our own experiences and remembering that all of us bring many hats to the work that we do. I also have been working remotely, and I also have 2 small kids who've been home with me since March, one of whom is in virtual kindergarten.
Fun. It's just timely what solution that you launched, and I think hopefully it's getting a good test drive at this point, especially with the first pandemic as your solution encountered. Phil, you're next on my panel here, and welcome again. And please share your background, your professional background, and then also your experience with COVID-19.
Yeah, I run a national free market advocacy group called American Commitment. We work really on all the fiscal, economic, and regulatory issues from the perspective of limited government. And we don't do original research. The idea is to get people the facts and the information they need to be a more active, engaged citizen, and write letters to Congress or into regulatory comment filings or into the administration, and try to tip the fights that are on the margin in a more free market direction. But obviously, the last 6 months, we've basically just been fighting against lockdown, because when you're on lockdown, pretty much no other economic issues matter very much. Nothing else really is of any significance other than ending that lockdown. So that sort of obliterated our normal sort of policy agenda. And in terms of personally, my mom died the first week we're in lockdown, and she was in California. I was in DC, so we had to have a memorial on Zoom, which was rather surreal. And of course, many, many more people have done it since, but we were probably one of the first. And then unrelated to that, because my parents have been divorced for a long time, my dad was hospitalized with COVID in Westchester, New York. He was fine, but it was really towards the beginning when everything was in panic. So that was a little bit traumatic, of course. And then we had dealing with all 4 of our kids being home. And, we've got, at the time that they shut things down, we had a 3rd grader, 2 2nd graders, and a pre-K-er. Now we've got a 4th grader, 2 3rd graders, and a kindergartner. And our Catholic school is 2 days a week, basically because our principal panicked when he saw the public schools closed and switched from 5 to 2. No logic behind it, just sort of an irrational, be happy with what you get. And it's been pretty useless on the not in school. The days he doesn't let them go to school have been pretty useless. And even the days that they're there are not very useful, because the teachers are spending half their time talking to the Zoom kids who are not getting a great experience at Zoom either. So it's sort of been, in some ways, the worst of all worlds, although I guess the worst would be no school at all, but it's been pretty bad for them, I think. So we're trying to make the case. I mean, it's been astonishing to me the extent to which the people who are least at risk have been forced to sacrifice the most, particularly children. So we're just trying to get more places to deal in facts and reality rather than irrational fear, and keep fighting these fights against lockdown.
Thank you. Thank you, Phil. And next is Leslie on my panel. Leslie, welcome. Can you share your background, and then also share how you are dealing with COVID-19 in your organization?
Absolutely. So thank you for having me. I am based in DC. I've spent the last decade or so in the digital health space. And so I serve as the Vice President of Government Affairs for Livongo. And we have been watching the rapid transformation of our healthcare system, as Duncan alluded to one that's essentially become digital overnight. And it's been exciting to be at the front seat to see this. Our members are living with chronic conditions, diabetes, hypertension, pre-diabetes, behavioral health. So they're all the ones that are predisposed to poor outcomes if they contract COVID. And so we've been able to employ our solutions and do the best we can to help those individuals stay healthy at home, arm them with knowledge, arm them with resources, and try to be as responsive to their needs as possible. I personally am at home with my husband and my 2.5-year-old son. My son is immunocompromised. He's living with cancer. So of course for us, keeping him healthy has been a priority and the reason why we've been home for the better part of 6 months. But I've also watched firsthand my parents, they live in the state of Vermont, so they've had a very unique scenario in terms of they're very much open after seeing very few cases. But they are both living with diabetes. And so they are both at high risk and they are new Livongo members. So, seeing how they've approached their experience with the pandemic, manage their risks is definitely at the front of my mind. And, but also knowing that they are 10 hours by car away from me, the fact that part of our Livongo solution, of course, is to have our coaches that are available 24/7. And so, early on, my mom had a very high glucose reading, and knowing that there was support there through digital health really is a value and is a great use case. And seeing them experience what it is that I've done for a living for a significant amount of my career really hit home. So again, thanks for having me and look forward to the discussion.
Absolutely. Thank you. Thank you for sharing your personal story and struggles around the COVID scenario. Well, I wanted to start up with a question for Phil at this time, and hopefully we'll fire up the discussion around that. So federal government wants to reopen schools and is distributing or testing people 100 million free tests from Abbott over the next few weeks. Few of the tests went out in August, and then more to come. Will this really help us to reopen, or is it really necessary, or is that are we falling short, or we are overkill this scenario of testing and opening up the schools? So Phil, you can start.
Well, I think, of course, as soon as I start talking, I knock my earpiece out. Look, I think the remarkable story of this particular virus with schools has been the lack of problems, really anywhere, almost no matter what type of opening you have, with one possible exception in the entire world, in Israel, although they opened up a lot of other things at the same time, including weddings and large events. And so it's difficult to isolate the impact of schools there. But basically every European country had no significant increase in community spread and no major issues in the school populations. And then we had this debate in back to school. In this country, well, are we like Europe, or are we a different situation because of relatively higher prevalence? And we have the answer to that now, which is we're not different. In fact, even with much higher prevalence, you look at places like Georgia, where, for instance, in Cherokee County, they opened at peak community spread while they had 15% positivity in the community when they opened, and they did no distancing and they did no masks. And if you go look at their latest, they post every Friday. They've got 42,000 students in Cherokee County. They presently have 14 active cases out of 42,000 students. They had to do some quarantining and that kind of thing where they did have cases. And so they've had some kids going out, but very small numbers every week. And basically the whole community spread has gone down throughout that entire period as well. And that was sort of the least aggressive in terms of containment approach that we saw anywhere. And there was essentially no problem with it. And so we're starting to see these stories now almost everywhere. Schools opened and, oh, we're so surprised there was no issue. Well, the question, I think, is why are we still surprised? When you see the same thing over and over and over again, we should not be surprised anymore. This should be expected. And it should be much easier for us to go ahead and open schools, almost regardless of what the context is of community prevalence. That said, that's not where a lot of people are. And you can't just say, well, look, there's been a great experience other places, let's open. If the teachers are scared to do it, if the parents are scared to do it, you need to address those fears, unfounded though they may be. And part of that is education, sharing the information, sharing the experience of these other places. But if you can also say, look, we've got this instant test, you're going to be able to find out, you're going to be certain that everyone who's in that school has been tested this week or whatever the frequency of the testing is. That goes a long way towards reassuring people in places that have been hesitant, that have been skittish to go back. And that may get them over that initial sort of status quo bias of I'm scared to do it. I think once they get back and they see there aren't problems, it becomes much easier. But overcoming that initial hump, that status quo bias is where I think that the instant testing can be very, very helpful. That said, I am a little bit worried, depending on what the test characteristics are, and if we see false positives, that it could have the opposite effect, that it could feed that panic and actually prevent opening. So I would like to see, I think that our kids and our schools are as important as our professional athletes. I'd like to see something like the NFL protocol, where you use the instant test as an initial screen, but then you use lab testing to confirm the positives before you consider them a confirmed positive, that the instant test would be considered a suspected positive, but you would have that additional step just to make sure you're not dealing with false positives. But I think it can be very, very helpful. The one thing that I would really like to see, though, from FDA is I'd like to see emergency use authorizations for home tests, because there have been some companies that with application, there was an MIT team as far back as March that put an application in for an emergency use authorization for a home test. They said they could manufacture at $1 and sell for $2 per test. Now, if you can get that price point, people can go buy 2 dozen of them and test themselves and their family as much as they want at home if they're going to see an elderly parent or somebody who's immunocompromised or just whatever the occasion is that they want to have that extra assurance. And the FDA's objection has been, well, it's not as precise as the lab test. It's not as sensitive as the lab test. Well, yes, but the lab tests are too sensitive. They're picking up infections that are 2 or 3 months old in some circumstances. What we really want is, am I infectious today? And the antigen instant tests are much better for answering that. So I think the Abbott emergency use authorization is a great step forward. I am worried that it can only be done by an authorized lab tech, though. I'd really like to see us take the next step, which is home testing.
Yeah, and I think innovations are happening definitely in that space. Talking about Nobel Prize, like our CRISPR technology just got 2 of our female scientists got the Nobel Prize on that, and it is a test that was developed in India, actually, surprisingly, based off of CRISPR technology that people can test themselves at home, and it's very, very inexpensive. It's just like a paper slip that tells you it's positive, negative. So there are several other innovations happening in this space, saliva tests and other things too. So that could be very useful. So this is great. Thank you so much. The question also for Duncan in that space is, you mentioned that you're cautious in opening this schools and other things. Can you also share your opinion on whether the test or no test will allow us to go ahead and open schools and other important facilities?
Well, let me clarify. The caution I have is personal.
Okay.
We all have a personal responsibility. Somebody said earlier we should wear masks not to protect us, but to protect the spread around us. And I wish we had that shared ethic, and we don't. On the issue of should we open up or not, let me put it differently. Should we lock down again? Absolutely not. It'd be insane. If you give me a second, I'll explain an example of why. There's been a lot of people looking back to the March call to have a lockdown, which was spread unevenly across the country in timing and scope. Said, why didn't we have a national response, shut everything down at the same time, stop all travel, no more flights? Sounds good. I think if we had done that, we probably could have survived easily for a week. We have enough stock of stuff, essential foods, medicines and all that. And maybe it could have stretched to 2 weeks, but after that, everything starts to break. The supply chain breaks, bad things begin to happen. And so I say to myself, okay, that's hypothetically very interesting. But at the time, we had no masks. We didn't have PPE here. We had no contact tracing. And we had a profound failure of our institutions all the way across. I mean, example is we had a really good plan under the Bush administration for if a big pandemic happened. Where is that plan? Nobody took it out of the shelf and used it. We had all this stockpile of PPE that FEMA was supposed to run. And I think a lot of it was used up when we had the swine flu come back again, the H1N1 in, I'm not sure it's swine flu, the H1N1 disease in 2009. Yeah. And okay, nobody replenished it. Nobody maintained it. There are people whose only job is to make sure that stock is there and happy and ready. And they failed in their only job. So with this profound institutional failure across the country, the lack of proper data, and I think one of our panelists really understands this deeply, be on the next panel after that, after this one. I think what would have happened is we would have tried it and we would have failed to have the real impact of it we should have had. And what's worse, when we did the lockdown, the quasi-lockdown, to flatten the curve for hospitals, we changed the goalposts. Hospitals were fine, but California is still semi-locked down. The supply chains would have busted. So my point is, I am personally cautious. I believe in masks. I think everybody should. But a lot of these hypothetical ways to solve the problem, looking back on it, wouldn't have worked or would have caused even deeper problems downstream.
Bambi, you're on mute.
I've never had Bambi speechless before. This is a wow.
This is what happens with a lockdown. You have kids running around like mine who just came over here. So
That's why I go in the yard so they can't get to me.
in fact, you can see them running around. In fact, I've been in conversations with the principal to be on sort of the reopening committee. And I think the earliest we can have is October 26th. And it's interesting, I was asking her about testing and how much she needed and how much the school needed to change to retrofit, you know, the school to bring students back. And we're in California, so it's pretty strict over here. So I think the earliest we can open up is October 26th. But so I want to maybe bring in Emily to see, I mean, what you're doing to try to help schools open up. I mean, given that Phil just, you know, talked about some statistics that that kids are not as or the infection rates are low in schools. I guess there's also a recent study, National Academies of Science, Engineering, Medicine, American Pediatrics, and CDC. They're pushing for schools to reopen, particularly for K-3. And I have a son who is in 3rd grade, so I would particularly like him to get back to school. And so, but it's not just about testing. There's a number of other things that need to be in place. And it feels like we should be treating the children a little bit differently, particularly if the studies are correct, that there's little to no transmission between a child to an adult. So what are you doing? What policies are you pushing to try to help these children get back to school? And this, by the way, is also, this is hurtful to underserved communities where you have single parents, right? And it's really difficult for them to be teaching their kids and working at the same time. What policies are you promoting?
Sure. Well, I think, you know, this is a really helpful discussion, and thanks for convening it. I mean, I think stepping back, the early response to the initial wave of the pandemic, which for some communities are in different phases of waves or prevalence, but the early response was largely designed in real time. We only had basic information. Our knowledge has continued to evolve, both about who would be most impacted, but also the impact of some of these prevention measures. You know, flattening the curve required taking drastic action, and, you know, it's, as was shared, I think it's questionable whether we fully utilized that time during the initial shutdowns to build the infrastructure needed. You know, I think what was shared is that I would agree that it needs to be both mindful of where people are and their comfort level. People are expecting their leaders to have comprehensive plans, to be monitoring and preparing for what happens in different scenarios in their school district, and hopefully preventing the need to open and then have to reclose. And I think that public sentiment and public comfort and confidence in the government and in their leadership to fulfill that is low right now. I think you know, people are rightfully concerned about the mental health impacts of distance learning and whether they're getting the education they need, but also not necessarily feeling confident that there's protocols and a plan in place. And I think part of that is the need for the federal government to provide resources for both the physical infrastructure for keeping the kids and the staff and the teachers safe. I think we can't pretend that the only people in school buildings are, between 5 and 18 years old. And I think the fact that many of the teachers have expressed concern, I think also goes to the lack of clarity and a plan that can instill confidence in their staff and in their communities that the schools are doing everything they can. And, I think to some extent, a lot of that response will require a level of federal support in order to have that infrastructure in place. And I don't know that people will, or cities will feel comfortable until they can have that confidence.
It's interesting you mentioned federal support because my son goes to a private school and a private parochial school, and they did not receive some of the funds. And they spent about $100,000 to retrofit their the school, provide more ventilation and just separation for the kids. It's interesting that the funds weren't flowing to the private schools or the parochial schools. Did you notice that, Phil? That the government funds to prepare or provide for these schools weren't flowing, were only flowing to public schools?
Well, the flow of funds under the CARES Act all flows either, it's in large cities, it's going through the cities, but other than that, it's all flowing through the states. And so, in California, you have a situation where you've got the state that is holding back a lot of the CARES Act funds, even for localities in a lot of areas, unless they'll comply with all the various policies that the government wants to see. So he's using that the governor's using it as a lever, in effect, and is holding back funds across the board in the CARES Act, not just the educational funds. And we're seeing a very uneven distribution of CARES Act funds because of the intermediaries, because in most places it's flowing not from a federal account to a grant applicant at a school. And I don't know that you necessarily would want that to happen because of the amount of processing that would have to happen at the federal program level. But what we've got is it's mostly flowing through states. In some large cities, it's cities, but it's mostly flowing through states. And so you've got a process that can be very difficult for even public schools to navigate, and certainly for private schools to be able to get access to those funds. It probably depends on a local government entity getting federal funds through the state and then subgranting them again to that school. And so there may be some places that are doing it well, but most places schools are absorbing those costs themselves, maybe hoping to get grant funding to reimburse it at some point. But I don't think that the money has been flowing very efficiently. And that's kind of one of the criticisms of just, we need another huge federal spending bill. There's so much money sort of that's already been allocated, but it's not getting where it needs to go. And so I don't know if the problem is that we're not spending enough rather than that we're not getting the money to the ground level where it's actually being used. And, in terms of the risks to faculty and teachers, I think that's largely been exaggerated to push a union agenda, largely unrelated to health concerns and risks, because the best studies that we have show that exposure to young children is more likely to be protective than to increase risk. There was a very large study of 300,000 NHS workers from Scotland that found that because young children have all sorts of immune challenges, all the colds, all the various things they have, that being around them tends to make you less susceptible to coronavirus because your body's seen similar things in the past. And, teachers have very, very strong immune systems, most of them, because they've been in classrooms with kids for years and years and years, and they've been exposed to everything, and they're pretty well positioned to do well with this and to do better actually than average. And we've got a sort of occupation studies from several countries, including Sweden and Finland, that found that the occupational exposure risk is about average or even lower than average for teachers compared to other occupations. And so it's true, there are other adults. You don't want to have the mixing in the faculty lounge. You want to be very careful for dismissal and drop off. You don't want adults mixing, especially if you've got like a large regional school or something like that, where it's people from all different towns coming together. So you do need to manage the adult interactions and take appropriate precautions, but schools actually have less adult interaction than most workplaces because most of the interactions are with children who tend not to be susceptible nearly as much as adults, and even if they are infected, tend not to transmit as efficiently as adults. So the transmission risks in schools, and this is consistent with the epidemiological data that we're seeing where schools are open, they're relatively lower risk than other workplaces. And so part of the challenge, how do you communicate that? And how do you educate people who are just naturally think children equal germs and aren't necessarily familiar with all the facts and the data that we're building up about this particular illness? And that's been a huge, huge challenge, along with sort of the resource challenges, kind of that public education challenge.
Bambi, or can I bust in and ask a question? Is that permitted in this? Because
yes, of course, yes.
Well, it's for both Emily and Phil, because everybody in this panel is part of the upper 40%. We have laptops we can hand down to our kids. We're on Zoom all the time. Look at us right now. And we know how to teach them how to be on Zoom and do remote learning. But there's a huge, I'll call it the bottom 40% if you want, a huge part of the country. Amber talked about this.
Yes.
Higher incidences of all kinds of health problems, including COVID, Black women and pregnancy and all that. We've heard a lot about this. What about them? I mean, making the decision whether we think it's good or bad for our kids to go to school or not and attend it in a very plush, private or high-end or suburban school. What about the other side of the country who are heavily impacted by this? I just would love to know what you two think on this score.
Yeah, I mean, I think it's absolutely raising equity issues, both of the fact that COVID is having a disproportionate effect on, especially on communities of color and also low-income communities for a variety of environmental reasons and jobs and, essential workers and other things. Like you say, folks here who have the luxury of staying home and continuing our livelihood, it's absolutely having a disproportionate effect, both the health effects and exacerbating some of the health disparities that have persisted for, forever, for generations. And, I think the flip side of that is certainly the educational equity issues. My son's in DC public schools. We're a Title I school, and there's a huge range of people who are, in need of technology, who may not have parents that can stay home and supervise. There's, discussion about reopening as soon as early November. And I think still awaiting details about what that means. I think it's a partial reopening and prioritizing. And I'm not sure how they're defining any of these, but both kids with IEPs, kids who need extra support, and prioritizing those populations for in-person learning. So, I think I think we're all here because there aren't easy answers, because keeping kids safe in populations where they that are already feeling disproportionate impacts of the disease, balanced against making sure that that communities are not falling further behind when their kids can't access education. And by the way, the fact that so many of the other services that they interact with are all tied to schools. When we talked about the immediate, sort of urgent shutdown in the spring, that, one of the biggest immediate actions was figuring out how to get kids the food that they need, because so many of those programs are run through schools. And the fact is that, schools are community hubs beyond just the educational impacts that are also being felt, and, the sort of unequal access to technology and other things that impact the ability to be successful in remote learning.
I would just add that, look, I think that school closures are a public health catastrophe comparable to, if not ultimately greater than, this virus. And the number of life years lost may be greater from the school closures than from the coronavirus, when you consider that the difference in life expectancy between a high school graduate and a high school dropout is more than 5 years on average. And we've got some school systems where 30 or 40% of high school students have not logged on a single time in remote learning with school closures. It's very hard to see how you're not going to have an enormous increase in the dropout rate from that. And that has massive population health impacts downstream as a consequence of that. And then just even in the immediate short term, the CDC has said that among the school-age demographic, we've got far greater excess, just the increase in suicides and drug overdoses, than we have COVID deaths. And so we've got a situation where school closures have killed more children than COVID has. And they're likely over time to dramatically, to cost a very large number of life years if we don't act pretty urgently to remedy the growing education crisis and to get the schools open. And, you know, I think there is an easy answer, at least substantively. The easy answer is to open the schools and to get the kids back in school. Politically, in terms of workforce and the unions, obviously that's pretty hard, or else it'd be happening in a lot more places. But it's a catastrophe. I don't think we should downplay the impact of it just because a lot of us are less affected. Although, you know, my kids are really upset. You know, my kids who have everything they could ever want, you know, with all the toys and the video games, whatever they could have, they don't like not seeing their friends. I mean, even, you know, they don't, you know, there's a social and emotional development effect here that even the well-off kids are being harmed with. So you can only imagine how bad that is for the people who are not well off and are suffering. You know, maybe the one safe place they go was school, and the place that they did get good, that they got, you know, nutritious meals and got access to mental health services and special education services and so forth. And I think that the special needs population in particular has been extremely ill-served by the closures, and some places have brought them back or are talking about bringing them back sooner. But I think there's a real legal issue there, whether they're getting an appropriate public education. I know there are a number of lawsuits that have been started on that question, but to me, even if kids were enormous spreaders, massive vectors of this disease, which none of the evidence shows, it would still be immoral to impose this kind of hardship on them when the disease itself represents such a low threat to them, less than flu for those age ranges. And so I think that to the extent you're trying to protect others, figure out a way to do it that doesn't impose hardship on children. And we should have been able to do that by now.
Okay, good, thank you.
Go ahead, Duncan.
No, I very appreciate the thoughts. So
Yeah,
back to you, Bambi. Back to the panel.
Leslie here from the tech side, but she has an interesting role because she's you know, tech innovator with Livongo, but also works with the government and to create some new policies. So just on the question, I wanted to talk more about just the older population, because Livongo really is targeted at those with chronic conditions, but also to tie it in with the schools. So do you see maybe there is a way to satisfy Phil by opening up some schools, maybe in communities where it's not so disproportionately affected by COVID? Those would be underserved communities. And I'm wondering if you're seeing any difference between underserved communities and then communities like ours, unfortunately, our communities that are a little bit in sort of the mid to upper tier. Is there, based on what you're seeing, should we be opening up schools for our communities and maybe not opening them up for underserved communities because there's so many other factors in play?
Yeah, so our member demographics are fairly representative in terms of, you know, where folks are across the country, and, you know, race generally maps to the general public. The one thing that we have seen kind of regardless ubiquitously across the board is a massive uptick in our members identifying themselves as stressed. So when you go through the Livongo experience, in addition to, you know, if you're checking your glucose, you'd also say how you're feeling. And one of the pre-populated tags is stressed. So we've seen about 30% increase in our members saying that they're stressed during the pandemic. And then we also, looking at our blood pressure readings, are able to map, it's a really neat interactive map, how we saw blood pressures increase during different phases of the pandemic. And so, I mean, there's no denying that there is correlation, causation, you know, however you want to couch it, between what's going on in terms of policy and reopening and locking down and reopening, kind of the different phases, and how that's translating onto kind of the average person. But, you know, we've also tried to be very responsive in the sense that this is such a unique time. And especially as we think about the mental health implications, generating enough content of, how can you cope with spending more time with your children, as glorious as it is for all of us to be at home with our children all day, every day. What is the implication of that, or losing a loved one? So we've tried to use the data, the millions of data points that we're generating to be able to customize our content, to be able to help, empower those with the chronic condition. So I don't think there's an easy answer. I think we've seen, in different pockets of the country with different political philosophies, how things are rolling out. But, the other piece that we've alluded to, and that our members will experience, and we've seen some political solutions to it, is just broadband. So whether you're talking about access to broadband from an education point of view or from a healthcare point of view, giving kudos both to Congress and the administration for facilitating, flexibility in some of those policies on the digital health side, to at least make sure that while folks are at home, they have as much access to healthcare as possible. So skirting your question about opening, but there is definitely data to show there's implications. But when you've got folks most at risk, they have to balance the potential consequences. So definitely taking a tech and data view of this.
Have you expanded Livongo into those underserved communities?
Not, growth has been, more or less organic. So whether it be with health plans, whether it be with employers, through PBMs, through some government insurance plans, I wouldn't say there's been any specific targeting of different areas and different communities. But given that there is likely to be a prevalence of chronic conditions among those communities, they naturally kind of fall into some of the folks that we're working with, some of our members. But then again, if you're thinking about those who may be on Medicaid, maybe uninsured, maybe, underinsured, the likelihood that their benefits, if they're even Medicare, up until the pandemic, was very, very slow to adopt innovative technologies and embrace telehealth. So a lot of this may be new to those communities, and they may not have been equipped. I mean, just looking at some of the JAMA article on how many Medicare beneficiaries actually have access to a smartphone or internet access or a computer, right? So I wouldn't say that we've necessarily targeted or seen any dramatic shift, but there has been more room for growth with those who may have been on particularly government insurance plans for adoption of new technologies and new modalities, and with some of the flexibilities from the public health emergency.
I mean, I think the CMS response to the telehealth coverage that included telephonic,
Exactly.
not just the video, is kind of the step in the right direction to kind of meet people where they are at. But I do feel like a couple things that are spurring out from all of the discussions that we're having is that, as we encountered COVID, because of a lack of very concrete and tangible response from our governmental agencies, somewhat the trust of people did get eroded. And I think that kind of has a fallout effect on opening up schools or opening up, other organizations, governmental organizations, or even private institutes, because we don't have a clear and concise guidelines for scientific based, and it's more kind of reactionary. The other thing that they've seen, like the response of our agencies in supporting healthcare providers, the first responders, was, I would say, diplomatically suboptimal. And in the fact that, each one of these folks were put at risk also makes the teachers and the nurses and the other folks to come back to school a little bit more nerve-wracking. The second part is we haven't utilized data as much as we're getting from the ground in a way that guides policy. So there's lack of trust, and there's lack of use of data that could actually allow us to educate people. Just like what Phil is saying, we have data, but we need to have a very trustworthy source that talks about, hey, it is okay. Like kids can actually go back to school, and here's why they can go back to school. This is a scientific approach, and these are the guidelines that we will do. When CDC passed on that guideline around opening up schools, it did some, and then it took it back, and then it gave it again. So people are not really trusting that policy.
I'm going to say this is a very profound point, and I'm glad you raised it today, because you think about this, we all want to quote unquote follow the science, but the science is sort of given to us through institutions. And we're in a period of time where we don't trust institutions to start with. You know, I don't want to put Trump in the center of this. He makes himself the center of everything. But when he stood in front of his panel on the task force, he's already living in a hyper-political environment, and that just made everything more hyper-political. And so it sort of amplified the noise. The media has been amplifying the noise.
Yeah.
There's been some really good people like Matt Taibbi who've written about this. Alex Berenson, always the former New York Times reporter, who've written about how the media have caused, to the point, I saw some stat that if you survey people, what percent of people have COVID in the country, it's like 30%. You know, really 100 million people have COVID. It's like stupidly so out of whack because they've been scared by all the amplification. And that means the institutions can't do their job. Not that they were doing a good job anyway, but this compounds the problem. So your point is, I think I want to amplify the point, which is, how do we trust people like Phil who say, data says it's safe to go back to school, the schools are actually a safer environment than a lot of others, and then blah, 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 nobody trusts Phil or anybody else because he's speaking against the institutional amplification of noise.
Can I can I jump in on this point? Because actually it's something I'm trying to do a deep dive in. So I'm joining the call.
You have to introduce yourself.
Yeah, sure.
And,
So
and also why you're relevant around COVID discussion, both of those things. Yes, please introduce.
Yeah.
Yes.
So I'm Rajiv Bhatia. I'm a physician, epidemiologist. I was with the San Francisco Health Department for 20 years. I developed the first health equity program in the country. I've created new laws. I evaluated evidence for the city. I've been through pandemics before, and I am just, I'm increasingly pulling my hair out, over the past couple of months, just to the point of the science. And I think when we have the little data session, although it seems like this is pretty free flowing right now, we'll talk about this. But so there is an established literature on the science you generate and use when you have a pandemic. There's a game plan for the science, like there's a game plan for everything else. The whole country has been off the game plan. And I really hold CDC responsible for that, irrespective of Trump. There is both in the domains. So in the domains of the questions like the schools, there's a set. So there's three groups. There's studies of transmission, studies of severity, and studies of and the surveillance to doing the disease burden. On the transmission, there are things called household transmission studies, and you look and community transmission studies. So you look in each setting and you look at pairs of infected to, the first primary to secondary infections, and you look exactly what the risk is in each setting. And when we had the H1N1 pandemic, we did exactly that. We knew that, kids gave it, who was giving it to who, which settings were how much. And the science that's come out of CDC has been atrocious. It's essentially what we call one cluster after another. So every setting in the country now has its own cluster study, right? But that doesn't tell us anything that's generalizable about risk. And it's negligence. It's honestly scientific negligence. A study I am doing, I'm working on with a colleague, and it's hard, is looking at every study and every output that CDC has done and evaluating it against the pre-established knowledge, needs. And I think when we get to the data piece, I'll talk about the particular problem about case counts because that is, case counts are not the way you measure an epidemic, but they are the way this country is running the epidemic machine.
Rajiv, I want to ask you a question. I think your point's exactly right. How do we rebuild institutions like the CDC after this?
Oh God, so I think you have to go back and I work, how many people have worked in a bureaucracy in the government? All right. So you know all of it's, so I'm trying to figure out why in the world would CDC not do the right science? Why in the world would it not clarify things? Basically the reason, so there's fear. Fear has driven the response, the political response more than the science, than actual science. The science, so if you don't do the science, then anybody can say anything. And confusion can reign, and with the uncertainty, there will be more fear and the response. So is this, how much of this is deliberate, because there is a deep animosity, and I'm sitting here as kind of a relatively neutral person. There's a deep animosity between the institution and Trump. And how much are they simply going to say, well, you know what, he owns it, so no matter how bad it gets, he's going to own it. So we're just going to sit there and be. I mean, that's one. The other is it's just it's chaotic. There's no organizational leadership. They don't. The people. So what's happening inside the CDC with all these studies is that there are EIS officers who are not. Are green. They're sitting around tables making study proposals for what they're going to do. The science is not being directed, right? It's not being orchestrated by anyone. So that's why, and so there's that level of chaos. They have to get approval for everything to do studies, and so it's being politically controlled by the high management of CDC. So how do you? I think you have to kind of diagnose what happened here. Is it organizational? Is it purely political? You need to get the other dimension is that this is now public health is this is power for public health, power that they've wanted for a long time. There is a tension between those people in public health that are for paternalistic top-down solutions and versus people-oriented solutions, and obviously one side is winning right now. There is public people who work in public health are institutionalists. They have loyalty to institutions over loyalty to anything, So there's a lot that has to be kind of exposed about this, and then the whole country's complicit. I mean, the failure to think and act critically makes almost and respond to fear makes the entire country complicit, and you will have to push through a lot of cognitive dissonance to get people to say, oh my God, we really should have seen the therapist earlier.
Regina,
and can I?
Yes. Is that?
Sorry, that's a lot.
We're going to be talking about data, but you're talking about politics, and I feel that we won't even be able to talk about data unless we talk about politics. Because unless we understand what your politics are, then maybe or maybe not we'll believe you. But so I just want to ask you a question. I didn't think I would ask this question, but I think it's a relevant one. Because you say that the institutions are, sort of have contempt for Trump, if, come November 15th and Trump wins, how does the next 6 months look like for the COVID reaction? If Biden wins, what does the next 6 months look like for COVID, the COVID response?
My prediction?
Because
we're not asking predictions because that could influence our audience's responses. But what we're asking is, if one person wins, what's the policy looking like? If the other person wins, what's the policy looking like? And we can all have our own predictions because,
Yeah, it's not who's going to win. It's
Yes.
given the fact that you said that institutions seem to be aligned with Biden
Mhm.
and have contempt for
Yes.
Trump. What is it going to look like in, because a lot of this seems largely political, and it seems like it seems like it would be a little bit smoother sailing with Biden because the institutions are going to be behind him. At the same time, you know, then we know what kind of science it seems like what you're saying is there's two different science.
I think that in either, I'm just at the top. I think in either case, it'll move back to the center, but for different reasons.
Okay. Well, I think also going back to Duncan's question is what can we do? Like you just described that, you know, CDC is full of cancer, like it has a disease, like we need to fix it because it's bottom up, you know, top down, it's dysfunctional. But we need to have trusted bodies that guide us during this time of crisis. How do we reboot that trust? How do we bring that back to our institutions? I think that's a critical question because politics influences, policies influences, trust of people influences what they do, whether they wear masks or whether they do distancing or not. And that influences our outcome. So it is essentially a dominoes effect. And then we need to figure out how do we influence making that dysfunction go away. Do we reboot CDC? Do we abandon it or defund it and go and create a new one? Do we learn from the private sector? Like a lot of companies have had a turnaround. They have pivoted and they have actually made themselves better. A classic example, Kaiser Permanente. They weren't going in the right direction. They had a Thrive campaign. They had an amazing CEO. They turned around, made it very modern and actually evidence-based and have way better clinical outcomes. If that can be done, how about CDC? Is that even a political will or policy will there?
So my simple answer to the question, I think just if more people do this, it's exposure and transparency. If people start to say, hey, CDC, you haven't been doing the science. You know, one of the first angles I worked on was, you know, California, give us the de-identified case data. You're not doing the science. Let us do the science. They didn't do that. It is very hard to object to transparency. Show us the actual, you know, Tom Frieden is a problem, honestly, right? He's saying things that are not evidence-based, and he should know better. It's like, show us the evidence. Let the people have the evidence. Let us, you know, start to push in that direction. There are good people in CDC that will, you know, they're better people and better angels, but they need to be held to account. And people need to be questioning and need to say, look, these guys may be the experts, but we can't let them make conclusory statements.
Bill has a, yes.
Could I just amplify one thing? You know, it's not even just that you've got a lot of people at CDC who dislike President Trump. They also dislike Dr. Redfield. And so we've got a CDC director who doesn't have control of his own agency. Mm-hmm. And we frequently have seen the director saying one thing while you've got the opposite posted on the website. Now, how can anyone from an outside perspective make sense of that? And which is the message of the agency? Is it what they're posting on their website and the positions that they're taking, or is it what their director is saying on TV, which is often in conflict, as well as the fact that both of them then change regularly, sometimes even swapping positions. And so it's it's very difficult to have institutional credibility when you have contradictory statements coming out of an institution, even simultaneously from the leadership and the rank and file. And, to a certain extent, you could say, well, the scientific process is going to have disagreement. There's going to be information. They're going to change as they learn more. But that's not, by and large, what we're talking about here. We're talking about really the political appointee at the top of an agency that has been unable to get control of that agency. And, for whatever reason, I think that's been the fundamental problem with CDC.
And I think regardless of of how the election turns out, I think what we've talked about is that there's a huge rebuilding of confidence and trust in institutions, in government to be able to manage this in a way that's, people can rely on, that it will actually follow the data and follow their needs. I served in the Obama administration at HHS as the liaison with state and local and tribal governments. And that was through H1N1 and Zika and Ebola. And, there was, and maybe it was more norms than institutional. The independence of CDC has certainly been an issue. And at the individual level, as we talked about, it becomes a political badge of honor to follow or not follow public health guidance. And, that just leaves all of us without a trusted source of information and being able to follow those guidelines.
And all of the countries that we were able to open up schools, people trust their system. They actually surveyed people in South Korea, not North Korea, South Korea, that they were able to open their economy and their schools because people trusted and followed what the government actually asked them to do during the time of pandemic. Scientifically valid information was shared with people, and they had masking, they had testing, they had distancing. And and that's not just one country. New Zealand and several other countries were able to do that because there is trust, and they downloaded their contact tracing, and that has not happened in the U.S.
Yeah, and I think Duncan talked about there's an overestimation of how many people have it, and certainly 100 million people don't have it. But I think there's also, on the flip side of that, a numbing to the numbers of deaths, or the fact that 7 million people have been infected and over 200,000 people have died from this that we're still learning about, and let alone the impacts that will be ongoing for many of those millions of people.
Well, I think I have, Rajiv mentioned that we're complicit in this, and I would say probably one of the biggest the one I would look at, the one institution I would look at that is really distributing and creating this division, it would be the media. And so they're doing us a huge disservice by not being very favorable or being biased or being impartial when they report the news. They have significant power, and I think they're abusing that. I do want to actually get this question out here before we move to the next panel, because we're going to talk about the CDC and data again, but are the negative effects of jobs loss, financial stress, mental health, the things that Phil talked about because he wants to reopen the economy and schools, are those secondary effects greater or less than the secondary effects of cardiac and kidney problems? What are your thoughts? For anybody who wants to respond.
Let me comment first as the non-armchair epidemiologist. I've been watching this so-called excess deaths measure. What are the excess deaths over normal deaths at the same time? And when the excess deaths from the COVID situation get down to the noise is the wrong word, people are dying, but get down to the level that we've accepted socially and normatively for deaths to happen in society, you get to a different question. And it gets back to why we should open or not open. There are all kinds of other problems occurring, suicide and all that. I noticed that car accidents, car deaths are still pretty high, even if people aren't driving as much. But the point is, once excess deaths from COVID get down into the level it normally would be, there seems to be little reason to so focus on COVID, we overlook all the other problems going on. The second part of this is the economy is bounced pretty well for a while, and now it's stalling. Why? Some of the biggest economic states in the country are still relatively shut down. The shutdown doesn't affect us. I'm still working happily. Everybody's got their jobs, getting paid. It affects the other half of the people around us who really have to go and do essential services, have to go to a place to work, etc. And they're the ones being severely impacted. So my conclusion, Bambi, is we should open up. We should have mitigation techniques like masks, etc. We don't just open, but we should open smartly. But we have to get the country going again.
Well, Leslie, your company Livongo focuses on chronic conditions. So what's your take on that? What's the greater risk?
I mean, I think we're still learning a lot too, right? We're learning about the long-term effects. We're learning about how folks with different predispositions, different genotypes, I think there seems to be a new study every day. getting to the overabundance yet lack of data about, what the course ahead is. So I think, we at Livongo want to do our best to make sure that our members feel like they have the resources they need to go about their lives, whether that means working an essential job or being able to stay home. But I think I don't think there's an easy answer. I don't think there's a simple answer. I don't think there's a one size fits all. And, it's not just tests, it's PPE, it's really having a preparedness strategy from top to bottom. Preparedness often results in confidence. And I think, it's been hard. There is no easy answer to so much of this. And, we've seen folks really try, and we've seen really shining examples of success, like what we've seen in digital health. But yet, of course, that's in a bubble and one, pillar of a much larger strategy. So, I don't have the easy answer. I don't have probably a good answer. But we've got to be cognizant that it can't be one size fits all, and we can't force it upon everyone either.
Yeah. This is something so if you look at the deaths, if you look at the deaths over the summer, you're going to see a peak in pneumonia, influenza, COVID, which is the COVID category where COVID falls in. You also see a bump, an excess death bump from baseline in heart-related condition deaths. You see an increase in diabetes-related deaths. These are not COVID deaths. These are deaths of neglect. You see a large bump in dementia deaths. These are people who were in care homes that basically had, they had a urinary infection, didn't go to the hospital at all, just died in the nursing home. There is going to be a natural conditions death bump. You're going to see a lot of deaths. And so if looking at excess deaths, those were not all COVID deaths. And I would say most of them weren't. I think that's point number one. Most of the U.S. had this very large number of deaths. If we had faithfully protected the long-term care facilities, our deaths would be the same as anywhere else. We neglected to do science. It's the only area with really good science-based interventions that we neglected to do. That's why we have a high death count in this country. Anxiety has increased. If you look at who does anxiety increase in, there is a dose response function between age and anxiety. The older you are, the less anxious you are. And the difference went from 11% baseline to 35% anxious or depressed in the country, with the youngest groups, the 20 to 29s, with the highest change year to year. It is just a no. It is, and now this issue is coming up. First, it was hospital crisis. Then it was death crisis. Then it was case crisis. Now it's secondary consequence crisis. Things are, I think another group that's complicit is the whole medical establishment and the medical journals. They are not giving the level of scrutiny to the studies that you can't do it. Who has looked, for example, at influenza follow-ups or any other respiratory virus? That would be the comparison. Does COVID cause any more sequela than any other respiratory virus in a head-to-head matchup?
Does it?
I don't think so. My guess would be
it
no.
looks about the same. I mean, it depends on the severity of the infection, but it looks about the same in general as any other severe respiratory viral infection.
Well, I think the long COVID and long hauler is being looked at partly because it's a novel virus, partly because people are at home and are experiencing newer symptoms they've never experienced before. And if somebody who had influenza like 2 years ago, and they still had lingering lung symptoms, they know that, oh yeah, I had the flu, I'll be fine.
Well, many of the celebrated long COVID people never tested positive. So I think that may be principally a psychiatric condition.
Yeah, well, there are some, there are markers and there are myocarditis and other things that, they were seen. There's real heart, lung, and brain issues that were found in the long haulers, but they're overinflated numbers too. I do believe that some of that are more subjective, and it has to be studied, but more, again, complicit healthcare system is more interested in writing more studies and research and peer-reviewed articles every day instead of going deep into each one of these and really paying attention to how much of this is like a cold and how much of this is truly COVID, and then put these symptoms in the context of normalcy in a way. So I absolutely agree with that. And asking the same question for you, Phil, like, what do you think? Yeah.
Well, I mean, I agree with almost everything that Rajiv just said. I think that the shifting rationales for continued lockdown and severe containment policies betray that the principal motivation of our politicians and so-called public health experts is to avoid admitting they were wrong, and that these extreme measures were not effective and are no longer necessary. But we've had this sort of path dependency, and we're on this track now where in order to get off of this track, they think they would have to admit that they were wrong, and they don't want to do that. And so instead we get this series of shifting rationales. And what I think ultimately, the way I ultimately think this ends is they will quietly change the definition of a PCR positive to 25 or 30 cycle threshold or something like that. And then the numbers will plummet. And then they'll say, see, we went away, we beat it. But that may depend on getting a president they like first before they're willing to do that. But I don't think that there will be I don't think we're going to see them say, wait a second, we made a catastrophic mistake. These lockdowns didn't work. We have no better outcomes in places that didn't do it in terms of COVID, and we have all of these other problems that we created. And so given that unwillingness to be reflective about the policy decisions and the recommendations that were made, we're sort of stuck, unfortunately, until they're either overruled or they have some elegant exit, and maybe it'll be from a vaccine or even a quasi-placebo vaccine where it's safe enough and they say go with it, and then they use that as the excuse to get back to normal. But I don't see great prospects for admitting that they were wrong, and I don't see much justification in the facts and the data for the continued severe containment that we have in so many places. And it's not everywhere in the country. That's the other thing. You need to have perspective. We've got about 10 or 12 states that are still on pretty serious sort of quasi-lockdown, and they've got 10 or 12 or 13% unemployment. And you've got 10 or 11 states that are pretty much completely open, and they've got 4 or 5% unemployment. And for the most part, they don't have any worse COVID outcomes. They actually have better COVID outcomes than the more lockdown states. And then you've got sort of the rest of the states that are somewhere in between. But the hard lockdown states, or they're not quite hard lockdown anymore, they're not stay at home, but I don't see any great prospects for them just saying, hey, we were wrong, so we're shifting. So it's very hard for them to navigate that exit.
Shifting, or but possibly recounting, is that what you're saying, Phil? You know, I do my own fatality. I kind of have my little spreadsheet. It's not scientific, but I do look at fatality rates across about 25 states, and Idaho is really low as far as fatality rate. You probably noticed that, but I noticed that that New York's death rates actually dropped, and I've been following it since June. And I thought, wait a second. And Duncan, I reached out to Paul and I said, did you notice this? What happened? Are they recounting? And I'm wondering if they would actually do that. They came back up, the numbers came back up. But Rajiv, you look like you had something to say.
Just to follow up, because and maybe this is a follow-up discussion, because it's the people you asked, what's the solution? Like, what is how do you fix any of this? And again, this is you take over. You have a group of people with integrity that are that are nonpartisan, that basically take over, that establish there's all of this politicization of this. We're going to be a neutral, a place where there is deliberation with all of the evidence of all the sides, and we're going to come to some reports or under some conclusions about each of these issues of conflict, about whatever they are. That's if you could. I think there are scientists and doctors out there who want a nonpartisan, who want to participate in a nonpartisan process where these debates where we can have a scientific debate about these questions, and we'll probably agree on what we can say we know and what we don't know, and what needs to be done. That's not happening. So creating a place for that to happen would be great. The point just on like the Northeast, I did a real quick analysis that I'm going to try to write up. If you divide up the epidemic so far into a summer wave and a spring wave, the mortality, and look county by county, the mortality rate in the summer wave is inversely related to the cumulative mortality in the spring wave. And that's pretty much, you can think, and this is like all the counties, that you can't blame this on, unemployment or mobility or anything. It's just, it really can only be a function of the decrease in the susceptibility, either a culling of the most susceptible people to death, or enough exposure to reduce the chance of the virus basically catching hold. So you basically have a functional herd immunity in New York City and and pretty much most of the Northeast.
You can only die once.
3:40, so we are 20 minutes already, and I see that Leslie and Emily already jumped off because they had to leave at 3:20.
Yes.
So we're going to bring in the other panelists, but Phil and Duncan, if you guys want to stick around because you have so much value add as well, feel free to stay on.
I'm going to go just because my wife's dealing with all 4 kids, and I've been in the yard isolating myself, so I need to go see what's going on. But
Okay.
thank you guys.
Yeah,
Take
please
your time.
connect, by
Thank
the
you.
way, in some way. It would be nice to connect.
Yes.
Okay.
We'll definitely connect the dots here.
So Bambi, I'll lurk here. I'm looking very much forward to the last panel. So I'll jump in if appropriate, but I really want to hear what they have to say.
Yeah,
With that,
if
with
Ron
that.
comes back, it might be extremely lively.